Good evening, everyone. Can you hear me? Oh, good. Thank you. First of all, I want to welcome everyone here. I want to welcome you to William Jewell College for our program, Medicaid Expansion versus Status Quo, What's the Cost? And I see there are a lot of people here tonight who are regular American Public Square members, and I want you to know that American Public Square at Jewell relies on its members to maintain its programming. So how many of you are members? Just raise your hand if you're a member of American Public Square. Okay, that's good. And so now look around to some people who didn't raise their hand. Your job is to not let them get out of here tonight without becoming a member, okay? We hope those of you who are not members will take tonight's opportunity to join. We would love to have you. Outside there will be a table in the hallway when the program's over. And I also want to thank the partners and the sponsors of tonight's program. Health Forward Foundation, who continues to support our programs year after year. We appreciate you very much. Children's Mercy Hospital, and KC Common Good. Now tonight you may have noticed there's a fact sheet, and we have fact checkers here tonight who are made possible by the William T. Kemper Foundation. Our fact checkers, panelists, and supporters who helped put this together have been kind enough to provide us with a number of sources and data that were unable to fit into tonight's fact sheet. So if you'd like to know more about what we're discussing tonight, we encourage you to visit our website after the event where we will host this information. And a quick point about that is that the reason you have a fact sheet that the panelists have reviewed is because we believe that having a conversation from differing points of view but with a common well of facts makes it not only a better conversation, but in this day and age perhaps somewhat unique. Additionally, special appreciation goes to our presenting sponsors tonight, who are the City of Kansas City, Missouri, the Hall Family Foundation, the H&R Block Foundation, PlexPod, and of course our home here, William Jewell College. Now inside your program booklet is a question and a fact sheet. It's that small piece of paper. It says on one side question or fact sheet. If you have when you have a question, or if you think something that's been said by one of the panelists is factually incorrect, write it down, hold it up, and a volunteer will come and pick it up from you. Allison Kelzer, where are you, Allison? Oh, right here. She is our roving reporter tonight. She's going to be asking the questions submitted by you. And Evelyn Washachek, where is Evan Washachek? I'm sorry, where are you, Evan? Oh, over there. Okay, sorry about that. They didn't tell me in advance. My apologies. From the Kansas City Public Library, along with William Jewell students, Jack Still, where are you, Jack? And Tate Cooper, where are you, Tate? Okay. They will be our fact checkers for the evening. Several members of the audience have civility bells that they're going to be rung if the tone of the conversation becomes less than civil. If you've got one, please ring it now. No one has one? Okay, well, I guess we have to rely on you all to be fairly civil. Okay. Finally, in the interest of keeping the conversation flowing and, of course, civil, we ask that you not clap during the panel conversation. So if you hear something that you agree with, we would encourage you to just do this. And if you disagree with it, you should just do that. But we'd like the conversation to keep flowing so that we can get something, keep moving. Now, it is my pleasure to introduce the president of William Jewell College, Elizabeth Mcleod Walls. But before as she comes up here, let me just sort of say, for American Public Square at Jewell and our new partnership with William Jewell College has been a remarkable success from our perspective. We feel very welcome and very much a part of this community, and we see this growing in a whole series of different ways, so we're really very happy to be here. So now, President Mcleod Walls.
Thank you, Alan. Alan has the unenviable position of introducing the introducer, because that's my job this evening. But before I do that, I want to thank you all for being here. As Alan said, and I can't underscore this enough, it really is a beautiful synergy between our two organizations, and we're delighted to be affiliated with one another. The thing that I'm most excited about, frankly, is that our students, in addition to the partnership itself, is that our students and our faculty are involved in the programming of American Public Square at Jewell, which is a tremendous opportunity for them to be engaged in the community, for our students to learn and participate, and so we're delighted by that opportunity for our students. But truly it is my honor and delight to introduce my wonderful colleague here, Dr. Gary Armstrong, who is also very involved in the programming aspect of American Public Square at Jewell, and who is a beloved faculty member who will be facilitating for us here this evening. Dr. Gary Armstrong is Professor of Political Science, Associate Dean for the Core Curriculum, and Coordinator and Advisor for the Oxbridge Program's Institutions and Policy Major. Having earned a bachelor's degree from the University of Oklahoma and his PhD from Georgetown, Dr. Armstrong is a leading voice in the areas of American foreign policy and security policies, international relations theory, and international political economy. Isn't that why you asked me earlier why you're facilitating a panel on Medicaid expansion? Yes, exactly. Dr. Armstrong is one of 2 William Jewell faculty representatives who serve on the American Public Square at Jewell Programming Advisory Committee, and he is a deeply respected academic leader at William Jewell, having served on our faculty for 27 years. We're delighted to have you facilitate this evening. Gary, the floor is yours.
Thank you. This is going to be a great evening, and you've already figured out my role. I know little about Medicaid. So I am here to keep things clear. When questions, when problems don't seem to be clear to me, I'm going to make the assumption that they are not clear to somebody else in the audience, and that I can help really kind of facilitate that part of the conversation. Because let me introduce people who know a great deal about Medicaid and will be our chief panelists tonight. To my left is Professor Dr. David Schlusky, a researcher, microeconomist, and associate professor of economics at the University of Kansas. His research is focused on health economics, labor economics, and public policy. And did I hear that this is your 3rd round with American Public Square?
Yes, that's right.
Welcome, Professor Schlusky. Excellent. Okay. Next to him, okay, we've changed our order, is Mr. John Bluford, president of the Bluford Healthcare Leadership Institute and former CEO of the Truman Medical Center. Now, if I have this right, he began his career as an epidemiologist with the Center for Disease Control. He is also the former chairman of the American Hospital Association. Next to him is Senator Jim Denning, the Senate Majority Leader for the state of Kansas. Before serving in that august role, he served as CEO to Discover Vision Centers. He began his career after college as a financial analyst in banking, and then at the Federal Reserve Bank in Dallas, Texas. And on the far end is Dr. Lee Norman, Secretary of Health and Environment for the state of Kansas. He has served as the Chief Medical Officer for KU Med. He has also served or serves in the U.S. military, and in particular as Senior Medical Commander during Middle Eastern deployments. Would you help me welcome our panel tonight? So I have a few questions for us to get started, and then we will take some moments in the course of the evening to see if you've already started to deliver questions that we want to pose through our roving reporter, wherever, oh, she's back there.
Right here.
So if you have questions, go ahead and put your hand up with the question, and they will get them to her. She can collate them. If some people are asking the same question, she'll be able to ask one question in order to keep us going so that we can have the best conversation possible. So let's start with the basics, Professor Schlusky. What exactly is Medicaid, and what does it do, and how is it different from Medicare?
Great, thank you so much. And thank you so much for having me. It's really amazing to be at William Jewell College, my first time here, and also to be back on American Public Square. As I'm a professor, I'm going to recommend you turn to your handouts, and you look at page 2 of our spectacular fact sheet, where you can see a graph created by CMS, by the federal agency that administers Medicare and Medicaid, about the differences between the two of them. The mnemonic that I use and that I teach my students is that we care for the elderly and we give aid to the poor. And so Medicare is broadly for Americans over 65, and Medicaid is broadly for Americans who are low income. Now, that's not quite right in that Medicaid is also expanded in a variety of different ways in different states over time to cover children, to cover pregnant women, to cover the disabled. But by and large, they're separate populations, though as a poor senior citizen, you could be on both of them. And they're also very different in that almost all of us, if we are lucky enough to live that long, will wind up on Medicare, whereas many of us, if we have not yet been on Medicaid, may never be on Medicaid. So they're very different in how they touch the lives of Americans. And they're also different that Medicare is a federal program, whereas Medicaid is a federal-state partnership. Everyone is different. The line is, if you know one Medicaid program, you know one Medicaid program. So all 50 and the state of, and DC, all 51 are different.
Thank you. Now, could you also explain how the Affordable Care Act's offer of Medicaid expansion was supposed to work and how it's working now?
So Medicaid is a federal-state partnership, has been since the beginning, more than 50 years ago, where the federal government pays somewhere between 50 and 70% of the cost, depending how poor the state is, and the state pays the rest. When the ACA was being set up, the general principle was to do something that would cover everybody with the fewest shocks to the rest of our system and have the greatest chance of bipartisan support in Congress. And so Senator Baucus from Montana, who's the chairman of the Finance Committee, among others, thought that for the lowest income Americans, though not low enough income to be on their state's existing Medicaid programs, we would just gradually raise the eligibility for Medicaid as we had already been doing state by state for the last 50 years, and more crucially, expand it to non-disabled individuals who previously had had a very hard time getting onto Medicaid. What the federal government said, right, the federal government can't tell the states to do something, the states are sovereign, but the federal government can say, if you don't expand Medicaid, not only will we not give you the extra money for Medicaid, which by the way was 100% for the first few years and will not go below 90%, we will keep all of the Medicaid spending that we are currently providing for you. A little bit like if you don't eat your vegetables, I'll take away all of tomorrow's food also. Leverage you could do, but might seem like a lot of leverage. And so many attorneys general thought that it was and sued. And in 2012, the majority of the Supreme Court said this is correct. This is too much leverage for the federal government. It's too coercive. And you can withhold the new money, but you can't withhold the existing money. And this, I think if states had to tell their citizens they were going to lose their current Medicaid, all would have expanded, which is why the law was set up that way. If citizens who had Medicaid wouldn't lose it, but citizens who didn't get it wouldn't get it, that was more politically possible, right? You're always much more sad if I take away something you have than if I don't give you something you would have gotten. And that got us to our current situation where each state can choose. We're down to the last quarter of states that haven't expanded, which includes Kansas and includes Missouri.
Okay, so if Missouri and Kansas take the deal, they will get 100% federal funding for the new people for a couple of years?
No, that ship sailed.
Okay.
Now they will only get 90%. They will have to pay 10% of the new Medicaid expansion, which, by the way, we'll get more into this, might include some people who are already on Medicaid at a lower rate. And so the amount the state will have to spend is not quite 10%, and we can talk more about that.
Okay. Secretary Norman and Senator Denning, could you go into some detail that we can all follow about how Medicaid is funded both at the state and at the federal level?
Let's see, is my mic hot? Okay. So Medicaid is funded very differently between existing Medicaid and then the expanded Medicaid. The existing Medicaid is funded with what we call an FMAP, and it's the percentage that the federal government matches state funds. We always say the match is 60-40, that is to say 60% federal funds, 40% state funds, but it changes twice a year. And I think when we go back to work in January, the state's portion will be 43% is what my guess will be. But for general conversations like this, we always say that existing Medicaid, which we call traditional Medicaid, is a 60-40 match. And then expanded Medicaid, the FMAP will be 90-10. 90% federal, 10% state. And the big difference is the 90-10 is a fixed percentage. That is to say, that 90-10, it would literally take an act of Congress to change that ratio. The existing Medicaid, again, it changes twice a year. So it moves up and down every year based on many economic factors that it would probably take a PhD to understand. We just take their word for it. But it's a very big number. That is to say, there's 100 basis points in a percentage, 1 basis point is $300,000 movement one way or the other. So there's been times when I've been on the budget committee that it's moved a whole percent. That's $30 million. Could be $30 million more from the state or $30 million more from the federal government on that FMAP. So it moves around, I call it violently. It kind of sets the tone for the whole budget when we get that FMAP number. So the expanded will be 90-10, and we'll be able to budget much easier for that than we can on existing Medicaid. And I can talk about the details of how the state funds its portion, but I'm going to let Dr. Norman chime in before I go into those weeds.
Oh, he'll go to those weeds, I assure you. Yeah. I'd like to leave a lot of the financial details to an economist and a finance expert, but as a physician, and I want to point out additionally that I've been a physician that's provided care to Medicaid patients for over 40 years. So it's not something that's brand new to me, I assure you. It's been interesting in my secretary role to dig into the healthcare finances, and it is a big and complicated program, I assure you. But I think from the broadest, highest level, it's exactly what my colleagues here to the right have said, and that is it's a sharing program. The portion contributed by the federal versus how much we have to produce at the state general fund level differs dramatically. I personally think that we're a little late coming to the party of expansion, in the sense that with the federal portion being roughly $1 billion at the 90-10 match, that's money that we've let go bye-bye in the state of Kansas. That's my personal opinion on that. And I will also point out that this this change in the Medicaid funding and the opportunity for expansion is predicated on the fact that Medicare reimbursements to hospitals have been cut back. And that was part of the underlying funding for the Medicaid expansion. It's a very clear purpose, which is to have less money going over there to hospital Medicare. So we've had all the pain of that. And I can tell you, for 26 years, chief medical officer, senior physician executive, large complicated health systems, there's no shortage of pain on the Medicare side for hospitals and health systems and providers, because the dollar amount has been siphoned out of the Medicare program and shuffled into the Medicaid program for those states that have chosen to expand. 36 states have chosen to expand. State of Kansas, state of Missouri have not chosen to expand. So we've had all the pain of the Medicare cuts to the healthcare facilities and none of the gains that could come in through the Medicaid program.
And just to be clear, either Mr. Norman or Senator Denning, does the money for Medicaid in Kansas come out of the general budget, or is there a special revenue stream for the Medicaid money?
Yeah, I was just fixing to answer that question. So the existing Medicaid, I'm going to round up. So fact checkers, round up. So the existing Medicaid program cost about $4 billion. That's the federal match and the state match. It's really 3.75, but I just rounded up to $4 billion so we can look at the differences. Of that $4 billion, 80% is funded out of the state checking account. That is to say, with tax receipt dollars for the most part, 80%. And then the other 20%, a lot of it comes from what we call an Hmo tax. We tax anybody that sells an Hmo insurance product in Kansas. We tax that product at 5.77%, and that makes up another 13% of how we pay for traditional Medicaid in Kansas. So that's about 83% of those. The state checking account pays about 80, and then the HMO tax pays about 13%. So that's about 93%. That's how we pay for traditional Medicaid in Kansas. If the Senate position passes and becomes law, or a version of it, then how we structured the Senate position on traditional Medicaid, we're going to do some stabilization, but we're not going to change the revenue stream. But on expanded Medicaid, how we plan on paying our 10% share is we're going to come up with a revenue stream that does not affect the state checking account. We don't want to put any more stress on the state checking account. It is under a tremendous amount of stress now. As a state, we spend $500,000 more per day operating the state than we bring in taxes. So we're in a permanent deficit spend. So when the Senate put its bill together, we wanted to have a stable revenue source for Medicaid expansion. So when that day of reckoning comes and we have to make a decision between raising taxes and cutting budgets, that Medicaid will not be on the cutting block, because we structured it so it will not have any state checking account funding coming out of it. So the HMO tax, because we're talking about a 90-10 ratio rather than a 60-40 ratio, will actually generate $63 million, and that'll be 52% of the expanded Medicaid cost. So that's half of it will be paid with that MCO tax. And then we're asking the hospitals, and they already do this, but we're asking them to have a surcharge / tax, and that'll be about 26%. So that those two items, that's 75% of the expanded Medicaid pay-fors. And the important thing to remember is on traditional Medicaid, 80% comes out of the state checking account. That's about $1.2 billion. And with expanded Medicaid, if the Senate position stays intact, it will be $0 coming out of the state checking account.
I think it's important to clarify that's 80% of the state portion. It's not 80% of the total cost of Medicaid in Kansas.
That's correct. We're talking about how the state's going to pay its 10% share. I thought that was the question.
Right. And if I'm understanding Senator Denning, you were saying that you favor Medicaid expansion if it is paid for by new taxes.
Yeah, the Senate bill that we had 2 days of hearing, obviously it's very comprehensive and very robust. It calls for Medicaid expansion on January 1st of 2021 with the pay-fors inside the bill that requires no state checking account money to fund the expanded portion.
Mr. Bluford, from the perspective of someone in the healthcare industry, leading Truman Medical Center, which in our metro area is frequently on the front lines of this, what's it like working with Medicaid? What kind of impact does it have on the people who were using Truman Medical Center?
Well, thank you, Gary. I'm sitting here listening to our first responders, to your questions, and I've been in the business 40 plus years. And this stuff is very complicated and contradictory. And it's very hard to understand, and I hope this audience leaves with just a glimpse of what some of these gentlemen are trying to share with you relative to the economics and financing of the Medicaid program. And the question that Gary posed to me is, what is it like working with Medicaid? And it was a challenging question to me because I don't work with Medicaid. I haven't. I have worked with a lot of people and patients who happen to be on Medicaid. That's a very big distinction. There is a major human element to the story. And I'd like to present my perspective on that. I work with patients on Medicaid just as I work with patients on Blue Cross Blue Shield, United Healthcare, Humana. It's all the same. The difference is the human condition and circumstances that many of our Medicaid citizens find themselves in, more times than not of their own making. The point is, most patients don't choose to be poor. Most people prefer not to be below the federal poverty level in their income stream. They don't like having unhealthy children. Ask them. They're just like you and I. In fact, they are you and I. I take a little issue with Dr. Slasky's point that none of us are in Medicaid or will be, probably will be in Medicare. Well, lose 2 or 3 checks, have a catastrophic illness, bingo, you're there, just like other patients in your circumstance. So on reflection, Gary, I have prided myself in giving quality care and good customer service through my institutions for everyone. And for those middle class patients like you and I, that was my job to make sure that that happened. But for the underserved, the uninsured, Medicaid patients, it was a mission. And the mission was to improve the lot and status of that clientele so that they, like us, can reach their full potential. It is imperative for people like us to help others who don't have, in my view, in my humble view. So I think my comment to myself here is that the idea is to make that patient cohort stronger because the strength of a community is as strong as its weakest link. And we need to bring that up. I have one case study that I share with you before I turn the podium, the microphone over, and this is a case study. And our institution was lucky enough to get about $4.5 million in innovation grant that came out a result of the Patient Protection Accountable Care Act. And we used a lot of that money to do a lot of case studies and case work with a zip code in the Kansas City area. So this is a patient. This is the circumstance situation that I was talking about a minute ago. This patient's a 40-year-old male, amputated below the knee as a result of gangrene in a toe. He has 5 diabetic brothers. He has lost 5 out of 8 sisters due to diabetes. His mother passed away on his birthday at 19 years of age. In interviewing him, he raises that, he brings that up. There's some trauma involved with that, I think. He's on 10 medications. He doesn't have a regular doctor. And he doesn't trust anyone. I wonder why. Those are the kind of circumstances, situations, human conditions that we need to deal with one way or the other. Doesn't matter to me who pays it, just has to get done so that we can be a stronger community.
Just to respond quickly, I certainly apologize if I implied that Medicaid cannot be a reality for all of us. But I think the difference between all of us expect to be on Medicare and most of us don't expect to be on Medicaid. And I think that crucial distinction is driving a lot of the political will behind the policy distinction we're seeing.
I could ask a question to anybody who wants to answer it. There are some people who have some strong concerns about Medicaid sustainability in general. And they worry about the number of doctors who accept Medicaid, which seems to be lower than the number of doctors who will accept Medicare. So what's the problem here? And what does it mean for expanding Medicaid?
Well, so the ACA, the Affordable Care Act, did actually consider this and had a provision that for primary care, Medicaid, which has the lowest, we call them reimbursement rates for technical reasons, but the lowest payment rates from insurance to physicians of almost anything in the country, because this having a primary doctor, having your doctor was so important, and because many of these individuals had not been previously insured, for the first couple of years, primary care Medicaid rates were increased to Medicare levels to exactly get at this issue, to get people to build relationships and get their chronic conditions under control. That was only a temporary window. That window has closed. And so one question potentially for Secretary Norman and Senator Denning is that, has there been any talk about having that fee bump window here in Kansas because we missed the first fee bump window that the ACA put together?
In my experience, physicians mostly will want to do their fair share. But in this era when there's so much pressure on medical practices because of Medicare and Medicaid are both, the payment rates are below cost. I can remember, for example, I had many patients that were foreign language speaking that I had to bring an interpreter for, and our practice paid the interpreter to be there more than we were reimbursed for the cost of by the patient visit. Think about that. You do not make that up in volume, right? So I think that on balance, what I think we as physicians hope for, and I think this is also true for hospitals, is that we want to do our fair share. And matter of fact, we would like to take care of everybody. From our KU health system perspective, I guarantee you, and Mr. Bluford agrees with this, Medicaid was a great payer, because otherwise they would have been uninsured and medically indigent, and there's nothing gratifying about sending a bill to a person that has no money. That is you talk about surprise medical bills and high cost of care. In some cases, compared to the uninsured and the medically indigent, Medicaid is a great payer. So it is our hope that, yes, that we can expand it more broadly. I can't speak for Missouri, but on the Kansas side, 130 to 140,000 individuals that would meet the expanded guidelines, because those people now are uninsured, and somebody's paying for that bill. The Blue Crosses, and the United Healthcares and the Aetnas, they're cost shifting to allow for caregivers to be able to stay in business, because if everything came in as either uncompensated or Medicaid or Medicare rates, healthcare facilities would be out of business. And that's where the problem comes from recruiting physicians into poorer areas and into rural areas, is because of the fact that the compensation rates are quite low. Again, everybody wants to do their fair share, and fair rates and Medicare rates are better than uncompensated care rates, I assure you.
Yeah, and you as an audience are also paying for that care through local taxes with county and city subsidies to respective safety net environments across the area.
Mr. Bluford, what do you think of physicians who refuse to accept Medicaid?
Oh, I can't say that in public.
Just one more thing on that, which is that I didn't mention this before, but Medicaid expansion is one of the most studied things I've ever seen in my profession. There are 324 studies in the latest literature review on this. I'm going to try to cite all of them if I can. But on this particular question, there are a variety on hospital margins and hospital profits. And Medicaid expansion was very, very good for hospitals, because this was mostly not replacing people that had private insurance. This is replacing situations for people who had no insurance. And you can't make it up on volume, but something is a lot better than nothing.
Yeah, as the doctor said, there's a lot of cross-subsidization going on. And back to your question, the private practitioner oftentimes does not have the capability to see a lot of these patients because of the complexity, dual morbidities of these patients, some of the social issues associated with them. Hospitals, teaching academic medical centers, the KUs of the world, the Truman Medical Centers of the world, have resources to deal with that, but it's not free. I think the budget for interpreter service at Truman Medical Centers is in the $3 to $4 million range. More times than not reimbursable by anyone. So I think I think society needs to grapple and grasp the enormity of the problem. And once it's decided it is a problem, then the answer has to be yes. We got to fix it.
Allison, we're ready to. Do you
All
have some
right.
questions?
Yeah, we have lots of great questions here, Dr. Armstrong. Thank you. We're going to start with one about mental health. One of our audience members would like to know, what are the implications for Medicaid expansion for mental health services?
Dr. Norman, you want to start?
So if I may repeat, the question is, what are the mental health services available to the Medicaid expansion population?
I believe they're asking to clarify what will be gained with expansion for mental health services and what is lost if it's not expanded.
Yeah. Well, one thing we know for sure is that the expansion population are people that are more likely to be having both mental health issues and substance use disorder issues. And what this does I feel there'll be more money in the system. In the state of Kansas, I can't speak for Missouri, maybe $1.2 billion total that can be channeled into many things, including, and quite honestly, and I didn't mention this before, I was a social worker before I went to medical school. I worked in a 5-county mental health clinic before I went to medical school, and I've always kept a close eye on community mental health. And for decades, the community mental health and substance use treatment has been gutted. And we do not invest enough in mental health. And I'm quite certain that by growing the pie with expansion, there'll be more money devoted to mental health care and to substance use. Because we're spending that money on them now, but it's called in corrections, it's called in state hospitals, and we will get and perhaps Senator Denning will want to comment on this at some point, because I don't know the dollar amount. But we will have some additional money come back into the Medicaid system, because we will, by increasing the mental health treatment and substance use, we're going to keep people out of prisons and keep people out of jails more than we're doing now. Because those are some of the largest mental health treatment facilities in the state, but unfortunately they're called prisons and jails. So we need to do better in the community mental health arena. Medicaid expansion will help with this.
Professor Slutsky wanted in as well.
Just wanted to say that pretty much everything Secretary Norman said is entirely backed up by many of the studies and the research done on this, on increased prescriptions for mental and behavioral health, on reductions in spending on criminal justice and other areas, and also on improvements in household financial situations, which can often be very linked and be drivers of a variety of kind of mental health concerns, about improvements in credit scores, in payments going to reductions in payments going to collections, in reductions in out-of-pocket spending, reductions using credit cards for medical bills. And I also mentioned, one of the reasons I believe so many of these studies is that the non-expansion has provided us a research opportunity. One where we have a large share of the country that experienced the rest of this country but did not experience Medicaid expansion, and we can look at the changes in those areas relative to the changes in expansion states. And that's a pretty incredible observational design and observational accident that is behind why we know so much about the benefits and costs of Medicaid expansion now.
Well, could I follow up just to make sure I'm understanding something? If Kansas or Missouri takes the Medicaid expansion, can they choose which services to cover? Can they say, well, we're going to cover these 2 or 3 mental health? Can they choose to cover infertility? Do they get to make those choices, or are those prescribed by Washington?
The states have considerable amount of leeway in order to design a comprehensive plan. Medicaid, and then we go through a process called the 1115 waiver, which is what essentially it's the arrangement we make with CMS, the Center for Medicare and Medicaid Services, the ones that write the checks, if you will, and approve our programs to do what we do. They have certain guidelines, and one of those is that it has to be comprehensive care. But within that, we can dictate. In the case of Kansas, we have 3 managed care organizations, and we're a managed care state in the Medicaid program. At least 95% of the care we provide is through 3 managed care organizations, and we can work to design the plan to have it weighted in different areas. Infertility would be an unlikely one, I assure you. Pregnancies, yes. Mental health, yes. So we have a considerable amount of leeway in terms of how we design the plan.
So Kansas would not have to cover mental health, but you think it would?
Oh, absolutely would.
Senator Denning?
Yeah, just starting from the very beginning, when you're talking about expanding Medicaid, you're talking about expanding coverage to the population between 19 and 64 years of age. Right now, Medicaid, it's literally impossible to get to get enrolled if you're between 19 and 64. So Medicaid expansion will cover the population between 19 and 64 years of age. So one would think that would improve mental health coverage as well. Second thing is, in the Senate plan, there'll be a recommendation that we apply for an innovation waiver. It's called an Imd waiver, and it's the institutional for mental disease waiver. And Kansas is in a unique spot to get that innovation waiver, because the letter that was written November 1st, 2017 by CMS said that they would entertain an Imd waiver for a state if they integrated crisis stabilization centers inside the waiver. Kansas is a unique state, and I know Representative Kathy Wolf Moore is sitting out there someplace. She and I worked together, and she did a lot of policy work. I did a lot of finance work, and Kansas has a national model for crisis stabilization centers that most states are trying to replicate. And because of that, we have a very good chance of getting an innovation waiver to expand the IMD. Right now, if you have a hospital that has more than 16 beds, Medicaid won't pay for mental health care. So we're trying to get that bed limit removed or raised up significantly. And because we have a robust crisis stabilization system already in place, we think we have a pretty good chance of getting that accomplished.
Thank you. Allison, where are you?
Dr. Armstrong, right here. We actually have a couple fact checks that we need to go over real quick. We'll get back to the conversation in a moment. Evan, are you ready?
Yeah, thank you. We had a couple of fact checks quick. One person was curious about the claim made by Senator Denning about the deficit increasing in Kansas. We were able to verify through AP data that the deficit will indeed climb between $7 to $8 million over the next 4 years in Kansas, or around that $5,000 per day factor. We additionally had another question concerning the claim that Medicaid's reimbursement is below cost for hospitals, and we were able to verify that with the most recent American Hospital Association data, the payment for Medicaid is 87 cents on the dollar, as well as Medicare is 87 cents on the dollar.
Thank you, Evan. And Dr. Armstrong, I do have another audience question, if that's okay. We have one from the audience about rural hospitals. The audience member would like you to, any panelists, to explain the connection between rural hospitals and Medicaid expansion.
Norman, you want to take it first?
The question between
Rural and Medicaid.
20% of the people in this country, and slightly higher than that in the state of Kansas, live in rural areas. Two, that less than 10% of physicians live in rural areas. So one, there's a mismatch already. Back to the earlier question about the low payments to rural areas, young physicians, and I might by extension say nurse practitioners, PAs, and others are not going to rural areas. So there's a movement away from caregivers from rural areas. Number two, I better not say a number, but a considerable number of hospitals, of the rural hospitals, the critical access hospitals, are in red ink, and and because they take care of who's there, whether they're Medicaid or insured or uninsured, they do not turn away uninsured people. So they've had real struggles. And I think that one of the things that is definitely true with Medicaid in rural areas, and especially those hospitals, is that it'll help hospitals to make ends meet. There's some that probably will not make it no matter that we do expand Medicaid. Some of the rural hospitals will not make it. Some will need to be redefined. What is health care in rural area needs to be, and probably all the hospitals. So I'm not going to sit here and say that every hospital will be resuscitated financially by Medicaid expansion. But many of them that are on the bubble, that are 500,000 to $1 million of red ink a year, will stand to benefit, many of them by a $2 to $3 million infusion for the people that are now medically uncompensated. So I think that the two things are medical manpower and stimulus to have people locate in rural areas, and the three is helping to sustain the local healthcare market to help to stabilize the population, really, because if people don't have healthcare, they move out.
How many patients or hospitals have closed since 2014 in the state?
I don't know the answer. I know that we've had either 4 or 5 this year in the state of Kansas. I don't, Mr. Bluford, know the answer to that since 14.
It's been 14 in Missouri since 2014. The other thing that I might mention, the 80-some% reimbursement rate on the Medicaid based on our fact checkers, does that include disproportionate share payments or not? And that's a big deal because there's a lag time in that. It's not only the percentage of payment, but the timing of those payments. And can you count on them? So the 80-some%, I suspect, includes disproportionate share payments. And those payments come much after the fact between the intervention of the clinician and the patient.
Just going to add on the rural issue that there are a couple of Medicaid expansion studies that looked at whether Medicaid expansion narrowed or even were able to close the rural-urban difference in uninsurance rates, which are much higher in rural areas. And all of those studies found that it narrowed that gap, and in some cases actually closed the gap, meaning that the uninsurance rate in rural areas fell more than in urban areas, such that they were about the same after Medicaid expansion.
Real quick, the fact checkers wanted to respond to Mr. Bluford here.
Yes, thank you. It appears that the AHA data does represent the disproportionate share as well, with that 87-cent figure.
So they may get the money, and Mr. Bluford has pointed out it may take them a long time to get that money.
So the reimbursement rate, and it takes a long time to get it, is closer to 55, maybe 60% on a good day. And then the disproportionate share payment, which comes after the year end, much later, brings it up to 85%.
Oh, so for 6 months, you're only getting, say, 50 to 60 cents.
That's a good bet.
Okay.
The other,
We're making that up. That's not a fact check. That was okay. Right.
but you're probably right. But the point with a lot of what we call safety net institutions, those places that take all comers, irregardless of ability to pay, 85 cents on the dollar is better than zero. And to the extent that we've got tens of thousands or hundreds of thousands of patients who are now under or uncompensated patients, no pay, and we get 85 cents on the dollar, that's a heck of a deal. That's a good thing.
Senator Den, can we ask you a political question?
Before you do that,
Okay, fair.
The fact checkers, are they checking something that I said, or it's a really bad echo over there, and I wasn't understanding even what they were talking about.
Do you remember which claim?
Yes, we had a question on the $5,000 contributing to the deficit per day fact that I believe you had. Sorry, $5,000 per day.
They confirmed what you said.
Yeah, we were confirming what you had mentioned. There was a cure. Yes, it's correct.
Okay, so getting into weeds just a bit, is Kansas has a very organized hospital system, and the federal government has a program, they call it an access tax, and the hospitals in Kansas, they tax themselves, we call it a health care access tax, and get a match from the federal government based on the FMAP that I talked about, the 60-40. So in Kansas, they generate a tax of $1, and they bring down a match of, say, $1.60. But it's the 60-40 match, and then they have their Medicaid fee schedule increased. So because they're so organized, they're trying to get their Medicaid rates very close to the Medicare rates. And there's been certain CPT codes that I have seen that they have been able to get their Medicaid rates very close to Medicare, and I think primary care is one of them. So I don't know if I'm getting into the weeds more than anybody's interested in, but again, the hospitals in Kansas are very organized, and when we go into the Senate plan, they'll be using that access tax to help pay for the plan so we don't have to hit the state checking account. But again, their goal is the procedures that they want to drive volume, that is to say primary care for sure. I'm pretty sure that they're very close to the Medicare rate because of their access tax.
Senator Denny, I want to ask you a political question because I don't think anybody on the panel seems to be opposing Medicaid expansion. So what are the kind of concerns and argument? Because you've taken more than a little heat with your decision to support Medicaid expansion and support taxes for it. But what seem to be the principal concerns, the main arguments that you're dealing with people who oppose Medicaid expansion?
So the political question, my title is Majority Leader. So the majority of the House voted to pass Medicaid expansion. They did it the hard way and gave us a pretty thin bill. So the rural folks in the Senate have asked me to bring a Medicaid bill to the floor next year that they can vote on. That was my commitment to the majority of the caucus. My title is Majority Leader. So they want a Medicaid bill that they can vote on. So the Senate put together a bill, and it touches many things that we've already talked about. Imd exclusion. It tries to drive down the cost of the ACA plans. The political question is why I'm taking so many hits from both sides of my caucus and across the aisle is several things. One, it does not have a work requirement in the bill. That's number one. Number two, it attempts to leave 100 to 138% of the federal poverty level on the ACA exchange rather than moving them to Medicaid. And the timing of trying to do that is not well received by my friends on the other side of the aisle. They think it's going to take too long. And then the work requirement, that's really important to many folks in my caucus, but we've looked at the work requirement from a financial perspective, social determinant of health perspective, and we think it's in our best interest to have a pathway to work rather than a hard work requirement.
Just on the work requirement, I want to agree with Senator Denning. The best example we have of this is that Arkansas, before the courts told them to stop doing it, had a work requirement. And what they found was that over 100,000 people ended up losing their Medicaid coverage through this, despite the fact 95% of them actually satisfied the work requirement, and that they were working a sufficient amount to meet the requirement on paper, but due to confusion, due to difficulty with the actual compliance of it, due to not having internet access, a whole variety of things, the work requirement didn't increase the share of the population working at all in Arkansas, but substantially lowered insurance coverage. We can get more into the weeds on this. On the 100 to 138% of the FPL, of the poverty line, the federal poverty level, just for a family of four, that's something like $25,000 to $33,000, $34,000. Fact checkers, give me plus or minus $2,000 there, please. 37, thank you. Which, by the way, that number is adjusted for family size. It's not adjusted for the cost of living of where you live. That's a whole fascinating other panel we could have about how we measure poverty in America and how we don't. But the issue is that the way if you put those individuals on the exchange, right? Their subsidies are such that their premiums are capped at 2% of their income, premiums alone, right? Which for those families is going to be, $500 or $600. But then once they have insurance, they then have to meet their deductibles and meet their co-insurance and meet their out-of-pocket maximum. The ACA did have a portion during the second Obama term where there was additional funds reducing all of that cost sharing down. The Trump administration ended that in 2017. So one challenge I see to putting the 100 to 138% on the exchanges opposed to Medicaid, even if you get the federal government to approve it, is that might still be underinsurance for such a low-income population. And states like Indiana have tried methods where individuals have to pay premiums and they might even be locked out if they don't pay them. And that, which should not surprise you, reduces the impact of the program.
Allison, do you have another question for us?
We sure do. We have one that the audience member would like to direct to Senator Denning. Republicans passed Medicaid expansion that was then vetoed by Governor Brownback. Why has it become such a tough political fight to simply pass it again?
There's a funny echo from the corners, and it's not that Senator Denning is that old. It's just that it
I will
bounces
repeat
back.
it. I'll come much closer. Republicans passed Medicaid expansion that was then vetoed by Governor Brownback. Why has it become such a tough political fight to simply pass it again?
The question was, why has it become such a tough political fight? So when Governor Brownback, we knew that he would never sign a Medicaid bill. So we didn't have enough members for an override. So now that we're back into the session and the House passed a Medicaid bill, the bill was built on the House floor with a gut and go measure, so there really wasn't any debate. It's come over with, and maybe we'll talk about it, like a permanent lockout feature. If you don't pay your Medicaid bill, you can get locked out of Medicaid for life. That is actually in the bill that came over from the House. So just think about that. So it's, that's what happens when you do a gut and go, and I've done gut and goes before, and it does happen. So the big political fight now is we have a Democrat governor that has a bill over into the Senate that she wants. She told me in my office, no changes. I want that bill passed. And now that I have many members saying, put together a bill that is different that we can vote for, and that's what we've done. And that's the process. It happens all the time. The House has their version, the Senate has their version. On almost every bill that comes through Topeka, that's how the process works. And this will be no different. The House has it's House Bill 2066. They've done their work. They did it on the floor, but it's over in the Senate, and the Senate's been working on our version for almost 2 years, but very transparently over the summer and fall. And we had, again, 2 days of hearings. Everybody has seen the language in the bill. They know what's in it. And when you have a bill that is getting ready for fierce debate or robust debate, it's the process, and more than likely the bill will be improved when it goes back to the House. That's typically how it happens. So I look for the Senate. I think the Senate bill is a good bill right now, but I think it will be better when we have debate, when we're back in session and amendments are brought back. So yeah, we're getting beat up from both sides, but that's actually a good sign, because there's things in there that nobody likes, but that means there's something in there that everybody likes. And it's just the process.
Do you have any advice for the state of Missouri as it thinks about it?
Vote yes. I think everybody's going to have to do what their constituents want, what their budget can handle. Kansas is taking a unique perspective in that we're going to try to have a Medicaid expansion bill that requires no direct checking account money.
It seems in the state of Missouri that there is more opposition in the state house to doing Medicaid expansion. It seems that part of the reason is that Missouri spends a lot more than neighboring states on Medicare, both Medicaid as a percentage of its budget and in the per capita that it spends. So there's something odd about Missouri, and it looks, from where I sit, there's a lot of things I don't understand about Missouri politics, but the probability of Medicaid expansion coming through the state legislature in the next year or two is probably very low. Very low. Although there is a move to put this on the ballot in front of Missouri voters for 2020.
I think there's a feeling among some pundits that if indeed it gets on the ballot in 2020, it's got a 50-50 chance of passing.
If it doesn't get on the ballot?
It won't happen.
Okay. So there's something different between Missouri and Kansas. Something is moving in Kansas, but at least in terms of the state house, is not moving in Missouri.
I'm not fully engaged in the political process anymore, but in conversations with the Missouri Hospital Association, they are cautiously optimistic that it will get on the ballot.
I think one of the really interesting questions about Missouri will be if something gets on the ballot and passes, will CMS allow it to go forward? Because that is not what happened in Utah. Utah had a ballot initiative that passed, and it had some features about it that were applied for through the process that Senator Denning explained, but the CMS didn't buy it, so they were not left with being able to implement that which was passed by on a ballot initiative in Utah.
Do you remember what the snafu was in Utah?
I'm sorry?
Do you remember what the problem was in Utah?
I think it was the partial expansion, wasn't it, Professor or Senator Denning, to 100% of the federal poverty level, and that was what was not allowed for by CMS. But see, I think there's something else that I don't want it to escape us, and that is I'm the secretary of the Medicaid agency for the state of Kansas. And one of the things that I do concern myself with is whatever comes through this legislative process, it gets pitched over the wall to my agency, and we have to be able to pull it off. And a good example is, and Senator Denning made comment about this, if somebody, for example, wouldn't pay a premium, they get kicked off of Medicaid for a period of time, have a lockout for a period of time, and then are invited back in or can apply again. That is what we call the churn. And imagine having hundreds of thousands of people, or in this case 130,000 people, having to reapply in a 3-month or 6-month period, how much that increases the workload. Imagine a family that on Halloween evening, on the 31st of October, they knew what their plan was. They got booted. They see their doctor on the following Monday morning, today, on the 4th of November, and don't qualify for Medicaid because they've been booted off in that period of time. That if I ever get gray hair, it's going to be over these exact kinds of considerations of how do you pull that off, because the churn would be remarkable, and we would have to stop. And I tell you, there won't be anything in the bill that says, okay, Dr. Norman, go ahead and hire 300 people to manage the churn that is going to be required for, I don't know, that wasn't a fact. It was just a hypothesis. It would require, so quit looking at me that way. So it would be possible then to make it difficult to implement something. So I'm not going to turn a blind eye to the logistics of locking people out, separate from the fact that that's the purpose of Medicaid is to enroll people for medical care. The purpose of Medicaid isn't to enroll people to kick them off every 3 or 6 month period. So we have to do something that's logistically possible to implement to reach the intended goals of Medicaid.
Gary, one thing the audience ought to appreciate in the state of Missouri, we've talked about the federal poverty level and the eligibility criteria tied to that, and it's around $37,000 for a family of 4 about 17,000 for a single person, federal poverty level. In the state of Missouri, the eligibility criteria is 22% of the federal poverty level. In other words, someone making more than about $4,500, $4,500 per year as a single adult does not qualify. That's sad.
Allison?
We do have from Evan, Tate, and Jack, we have a fact check that we'd like to reply to.
You are keeping our fact checkers busy tonight. This is
We had another inquiry into that 87 cents on the dollar note from earlier. This one's concerning Medicare specifically. I was able to find a New York Times article that references that same American Hospital Association data that says on average the government program, Medicare that is, pays hospitals about 87 cents for every dollar of their costs. So I just thought I'd go.
Thank you, Evan. We do have another question as well. This one's taking it in a little different direction. Change the conversation a bit with this one. How will Medicaid expansion affect those who are currently insured without Medicaid? Will premiums/deductibles be increased? I'll read it one more time while we decide who's going to respond. How will Medicaid expansion affect those who are currently insured without Medicaid? Will premiums/deductibles be increased?
I think one of the questions there is, will people lose their insurance because they're now eligible for Medicaid?
One thing I'll mention is that remember that the Medicaid expansion didn't happen in isolation, that the regular marketplace healthcare.gov expansions came online at the same time. And so there is evidence that states that expanded Medicaid had lower premiums in the market. Which is consistent with what we've been saying so far about kind of who ends up paying for uncompensated care in states that didn't expand Medicaid.
Anyone else care to respond to that one? All right. Why do we keep trying to solve tomorrow's problems with yesterday's techniques? We don't do that in other industries.
Well, we don't
Don't shoot the messenger.
I disagree with the question. We don't do that in other parts of the country that are not the government. But in other parts of the government that are not healthcare, that's exactly what we do. So I think the underlying question is, why doesn't the entire government work differently? And I'm not sure if that's the responsibility of the four of us to solve.
Mr. Bluford.
Well, one of the responses that I like to share with different audiences that crystallizes the issue as I see it. It's a political issue. And that is, people always claim about the rising cost of health care and how much more expensive it is in our country than other developed countries around the world. And the answer is this, in my view. Just keep in mind, for everyone's expense, someone else is receiving revenue. Costs me more, but somebody else is getting paid more. So there, it's a sum zero game. It's winners and losers. I mean, I went through a lot of the debates during the Affordable Care Act development, 2009, 2010, midnight phone calls with different entities across the country. It was just amazing how you could reach a conclusion and an agreement, and then pharma gets on the phone. And 340B doesn't happen because it's costing them big money. And until we can get out of that loop, it's going to be very difficult to make wholesale changes in the system.
It was a really good question, and let me give you an unintended consequence of modern therapy. There's a newish drug called Zolgensma, and it is used, it's gene therapy, which is very modern, right? And there's an unusual condition, I won't go into it, but it's in newborns that leads to them to have kind of a muscular dystrophy-like condition. if you do the gene therapy in their first months to year of life, it can change their genetic structure such that they don't have that illness that would make them wheelchair bound and all the human consequences that would go with 24/7, 365 care. Okay? Boy, that sounds good, Lee. $2.12 million per dose. And it's typically only given one time because either it works or it doesn't. But imagine what a budget buster that is. And we have 4 patients now in the state of Kansas that qualify for Zolgensma, $2.12 million, and that's our cost. Doesn't even get to what Mr. Bluford talked about, which is what is the pharmacologic big pharma markup in that kind of a product. So very modern things can also be very expensive.
But I'll just to comment on that, expensive does not mean inefficient, and cheap does not mean efficient. So another example I often talk about is Sovaldi, the hepatitis C drug. I'm not that kind of doctor, so please help me if I say something wrong here. But my friends from the UK, right, in the UK has a nationalized system and basically has a panel that has a threshold, and anything that can extend life or improve quality of life that costs less than that threshold, they fund, and anything above it, they don't. So when American insurance sees a drug like Sovaldi that is very expensive but can cure hepatitis C, they want to run the other way because they're only going to have you on their plan for 2 or 3 years. The UK looks at that drug and says, you can take a sick 25-year-old and make them a productive worker for the next 40 years. Get me 10 of those. That's an incredible deal for our society. So I think we need to be careful about expensive not meaning inefficient and cheap not meaning efficient, but also have to take a broader perspective of, the goal is not to keep you out of the doctor's office, right? The goal is to have you be healthy and working and happy and have enough to afford your expenses. And that's what we're going for here. And I think we should step back to make sure we're thinking about that.
Allison or Adam, we have time for one more audience question.
All right, this one included a lot of information, and it is an audience member question. How do the states plan to respond to federal leadership and how they are continuing to chip away at the Affordable Care Act? Specifically, this audience member pointed to the coming weeks, the planned ACA decrease to the safety net and rural hospitals that is putting more pressure on healthcare, rural healthcare specifically. I can elaborate once more. I'm piecing it together.
Well, and I'd kind of like to add on to that. I know there is important litigation to try to overturn the ACA, and that will be coming to a head, I gather, in the next 6 months. If the ACA were overturned, do states that took the Medicaid expansion, are they left holding the bag? So a question about responding at the state to what's happening at the federal level.
You're talking about the Texas lawsuit, if that would overturn the ACA, then because of the 90-10 match, the states would have to make a decision. We'll just use Kansas since we know those numbers. So expanded Medicaid will cost the state of Kansas $121 million per year. If the ACA was overturned, it would cost us right at $1.1 billion. We only generate about $300 million in new tax revenue, so obviously we'd have to shut the program off.
So if the ACA were overturned, it would cost Kansas $1.1 billion. You have about $300 million. Is that what you said?
That's to fund the entire government.
The entire Medicare or Medicaid.
That's the fund the entire operation of the state.
My university too. That's all. That's a lot of stuff.
Okay.
Senator, is there a provider tax that covers some of that the hospitals pay?
Well, the hospitals right now pay about $121 million or so in provider tax, but it's already built in of our share. So I don't look for it to be overturned. I think it'll continue on, even if it goes to the Supreme Court. I look for the appellate court to turn it down, but if it goes to the Supreme Court, I look for them to keep it in place.
I agree.
And keep in mind, there's 36 states that are pretty happy with Medicaid expansion.
And one District of Columbia.
Yeah, and the elected officials that are from those states will have I think a considerable amount to say about it. Adding on to what Senator Denning said about the Supreme Court.
That's good.
As we move to the end, the traditional American public square way to end is to ask the panelists to get ready to handle two questions. The first question is, so what? And the second question is, now what? If you were to summarize your basic view in a short sentence or two about so what, what's at stake, what matters here, then the second question is, now what should we do? So two questions, so what, now what?
There's one more study I didn't mention that used Social Security mortality data and showed that the mortality rate for people 55 to 64 in the Medicaid expansion population went down 9.4%, which would be about 72 deaths per year from Kansas and about 194 deaths per year in Missouri. If you divide that for Kansas by the 47.4 million number the Kansas Health Institute says is the net cost per year, that gets you about $750,000 per statistical life. And most state and federal agencies use a threshold that is 5 or 10 times that to choose how to make policy. You can figure out the now what.
The so what is that in many instances, Medicaid is life itself for many of the people who need it. It's a life or death proposition. And the question is, having a healthy environment, a healthy community, a healthy city, a healthy state, it's a public good. Forget it's a right, forget it's a privilege. It's a public good to have a healthy population. Healthy populations are more productive. You heard a little bit about the mortality rates and how they improve when people have health care. There have been a number of studies that have been stated. Oregon State, I thought you were going to bring that up a little bit, has a classic research project because they had a lottery and X number of people got Medicaid expansion, X number of people did not. And guess who's doing better and it's more productive and heavier? The people who got it. So I think the answer is yes, we need to do this, and we need the political will to make it happen.
I think where Kansas is, especially when you have time to look at the Senate position that it will be going over to the House, is that the Senate position is looking for giving health care access to the Medicaid population as well as the non-Medicaid population. We're talking about the ACA exchange market. I sat at dinner tonight with a woman, and she said that she buys her health care on the ACA. She spends $500 a month in premium, but she has a $5,000 deductible. When you see that Senate plan, you'll see that we're asking for a waiver, an innovation waiver, to give that very same scenario first dollar coverage up to $1,000 before her deductible would kick in. We're trying to give access to Medicaid and non-Medicaid. We're just not stopping at Medicaid. We're taking a big bite of the apple. Going forward, we're talking about health care access. Going forward, I'm talking about the session 21 and after, we will be looking at affordability issues. That's a whole nother discussion. It's not for tonight, but Medicaid expansion is giving access to health care. And once we get that completed, we will then shift all of our focus onto affordability going forward.
I think the so what is that we in the state of Kansas can afford Medicaid expansion. And so I think what now, I think it's really critical, and I'll look to Senator Denning and colleagues really on both sides of the aisle and both houses to not make it so complex that it gets delayed and delayed. And the so what now, meaning that with the the support of the Affordable Care Act exchange is something that can be done without having to slow down Medicaid expansion. Those two things are not tied together at the hip, and I would not want one to slow down the expansion of Medicaid, because we can afford Medicaid expansion. I agree with we want to stabilize the Affordable Care Act, but it can be done in a separate and parallel track and expand Medicaid. And I think it's important not to muddy the water and to make sure that we can think clearly about that.
Everybody on the panel, with one exception, has been from Kansas. If you are a resident in the state of Missouri, there are going to be two people from the campaign to get the signatures to put this on the ballot for voters in Missouri in the lobby, and you can sign their petition to try to get that. Now, that's not to decide the question. That's just to get the vote in front of Missouri voters to decide the question. I have learned a lot. Would you help me by thanking our panelists tonight? Thank you. Thank you.